I think now we're going to move into a case study discussion, and hopefully you'll be able to carry in some of that hippocampal atrophy that we talked about as we start to talk about what is going to, how potentially we can get Lainey feeling a little bit better and off her dual opiate, dual benzo treatment plan right now. Nora's going to join us. Okay, so you guys remember Lainey from the video, and we introduced her at the beginning of the day today. So she has a TBI from intimate partner violence. She has a diagnosis of PTSD, major depressive disorder, and then she has persistent low back pain. I think some key things here that she's never been in targeted trauma therapy before. So she's been in community mental health where she's had case management and maybe psychiatric medications, but she's never had some targeted PTSD therapy. Her community is really in her building, and her strength is Chloe the dog. Remember that dog?
So, and then to go over her pain presentation, and what we're doing, we're passing around some worksheets, and we'll ask you to work individually and then in groups of two, and then we'll come together as a whole group. And what we'd like to do is identify what some of the aspects of the neurobiology of trauma and the neurobiology and neurophysiology of pain that we've talked about, what you're seeing in her story, and what specific treatment interventions might be helpful for that. So, you know, one of the things that can be overwhelming in working with complex pain is like sort of, I don't know, maybe we should do this, maybe we should do that, kind of scattershot. And in fact, if you start to think about what is behind the presentation that you're seeing, you can start to think in a little bit of a logical fashion about what might be appropriate, especially with the resources that you have, for example, with back pain and the new benefits. So her pain presentation, again, she has low back pain that's spreading in area across the lumbar spine bilaterally and into the left lower thoracic. Hard to tell where it is sometimes. Worse with cold weather.
They have this snapshot document too in your handouts.
Worse with, thank you, I said on that. This is in your in the front, I think, of your book. Worse with walking. She has moderate degeneration on X-ray in the lumbar spine. No MRI has been done. She thinks her condition is terrible and that something terrible is about to happen. She does not have any PT that she's done in the past with some barriers to that, and she shows up in the emergency department frequently. So I think what I'd like to have us do is let's take around 5 to 10 minutes of just looking at, make sure you have your case out so you can refer to it, and then looking at that grid, think about some of the aspects of her sensitization picture. In fact, can I have the clicker? Oh, yeah. Yeah, so in terms of her sensitization picture, we looked at nerve sensitivity, sensory cortical changes, increased coupling of brain function with pain, and imbalance of arousal. And do you have it? And then, oh, and then we also added social. And I think there could also sort of be an other category as well. So what I'd like to ask you to do is to spend about 5 to 10 minutes looking at the case and looking at the grid and thinking about what you're seeing in terms of what's happening with her nervous system. And then what, across the top, are some of the interventions that can be done. What interventions might address some of those nervous system changes. So have at it. And then we'll get together in twos after that.
So could you explain it so that I understand?
Oh, good question. So the question was, did we talk about which of these affect which of these? Can I take a look at this for a second? So that's kind of part of maybe the problem solving to think about. But let's do that together. So if the different categories we have here include nerve sensitivity, sensory cortical changes, brain functions being coupled with the pain response, imbalance of arousal, and social. So let's look at that together. What would pain education affect in that column of changes that happen with pain and trauma?
Oh, I see. Okay. Everything. Yeah.
It might change everything, yeah. What would behavioral health have an impact on?
I see.
So for example, I would say chiropractic And many forms of physical therapy, if they are passive, so physical therapy might do passive manipulation, it might work with physiological quieting, and it might work with helping people return to activity. If it's passive, or the chiropractic aspects of chiropractic that are passive would not probably change the sensory cortex as much or change the brain functions, right? It's focused more on direct tissue intervention, which is actually not even on this, right? So, not to say you would never, except for the placebo part, which is relevant, but maybe not something you want to spend 12 sessions on. Yeah, so this is a way, so the idea here is to think about, okay, why would I choose, of the benefits, if they have a complex case and they have 30 visits,
Oh, I see.
why might I choose one versus another, right? So physical therapy in some cases might address all of those, in other cases it might not. Behavioral health would address some of those things. It would not probably, it might affect sensory cortical changes if it helps them start to be less fearful of movement, but it won't actually probably coach them back to movement. So a combination of the two. So this isn't like a totally exhaustive grid, but a way to start to think about what the pieces are of the interventions that you're offering. Does that make sense?
What about the chemical dependency column? What is that specifying?
Yeah, that might.
So treatment for chemical dependency?
Treatment for chemical dependency, yeah. Which might be about arousal, social, yeah. And it's, you know, there's probably other ways we could set up the grid, but it's just to start to think about those different pieces and how you are addressing them with the plan of care. And then we can develop, and then we can talk further about it. So you don't have to feel like you've got it all nailed down either. Maybe we can bring the group back together now to talk about how we're going to develop a plan of care for Lainey. So maybe what would be useful first is to go across the columns and talk about what people think different treatments would affect or not affect. Just to kind of flesh that out and get different people's perspectives. There's not one right answer. So what about nerve sensitivity, that increase in gated ion channels that can proliferate and create greater sensitization? Across the different treatments, which treatments might have an impact on increased nerve sensitivity? What do you guys think? Huh? Acupuncture, okay, great. Any others? Because it's probably the general sort of move towards resilience and less of a sense of threat over time is going to direct the nervous system to allow those extra channels to die back off. Yeah.
The physical therapy gradually increasing activity?
Yeah, physical therapy gradually increasing activity with pacing might do that. What else?
Possibly chiropractic.
Okay, how so? How chiropractic?
Possibly just decreasing pain somehow with manipulation, I'm not sure.
Nerve or irritation, possibly, is there structure?
Yeah, maybe. I think there's a risk there, though.
Did you make her?
Well, this gets to a comment that we were talking about here about what you introduce first. Chiropractic and acupuncture are primarily passive interventions. Well, they restore resilience. Let me say what I'm saying, and then you give your response, which is great. There's no one specific answer. But the risk of something that a person perceives is being done to them is going to bias people towards a little bit more of that external locus of control, which is what got them down the rabbit hole in the first place. So you have another thought, so I'd love to hear it.
Well, I mean, when you consider chiropractic, and I feel like this is kind of the problem with we don't have interdisciplinary education of what that offers, is you have people with serious musculoskeletal problems, and within that you have the neural system. And when it's impinged by what they're experiencing, whether it was trauma or whatever, you do have that constant stimulation of that nerve. And you have
Correct,
increasing
right.
receptors, so when you alleviate that by traction or decompression, you have that relief of
Mhm.
stimulation and then the downregulation of those receptors. So, and sense that is nerve sensitive.
Okay.
And I agree with that.
And I mean, the incorporation, a lot of chiropractic incorporates massage, as part of their treatment, so that I can see that correlation too.
Yeah. Okay, yeah, great point. What about sensory cortical changes? What would have an impact on sensory cortical changes? What has an impact on sensory cortical changes is moving.
Yeah, PT.
So PT would do that.
Also said behavioral health to help them with their fear of movement.
So behavioral health to help with their fear of movement, and pain education to help with their fear of movement.
Occupational therapy to help them kind of figure out if they need tools, external tools to help them be able to move in a better way.
Right, great. OT to help with tools for living. OT is not a covered benefit, so I don't know how that works in the CareOregon world, but it certainly is something that we use a lot in complex pain. Yeah. How about brain functions becoming coupled with the pain response?
Behavioral health.
Behavioral health?
And
Mhm.
education.
Pain education. Mhm. And getting moving will start to change that. And slowly returning to activity with a sense that you're sore but safe.
Again, occupational therapy, chair in the shower so that they can shower, be doing their ADLs and
Great.
kind of feel empowered with some additional tools.
Great, yeah. And actually, we hadn't talked about the role of speech therapy, but speech therapy has a huge amount to do with problem solving and comprehension as well. How about imbalance of arousal? Pain education and behavioral health being the big ones, yeah. And maybe chemical dependency, too. Yeah. And acupuncture would be a big one. I would agree. And then her social complexity. Pain education, behavioral health, chemical dependency, yeah. So that's some ways of thinking about what might most impact what in developing a plan of care. When we think about Lainey, what do you think would be an important place to start? Like, getting back to the question about nerve sensitivity, and I think the fact that it was at the top kind of makes you think about those more direct treatments a little bit more. Is that a place to start? So for example, if she came to me and she had all kinds of mechanical faults going on in her spine, but she had her level of arousal, I wouldn't go directly to her spine, although I might ultimately do manual therapy with her at some point. But the risk would be, if I did that first, then she's going to still have her whole system sensitized. And so when I try to help her return to activity and she feels painful, she's going to have a problem with that and maybe not come back. And that which makes me think of the conversation that you guys were having over here. Can you share a little bit of your thoughts?
Yeah, I remember you were saying how when you went to chiropractic and acupuncture, it was like too much. It brought up.
Yeah, well, big group, sorry.
Oh, no. Well,
No, so just, I have a trauma history myself, and I thought that I had a very good control over it, and I didn't think that I needed behavioral health or anything like that for pain issues. And started with chiropractic, and going there, it really shocked me because I had all kinds of stuff just trigger that I thought I had already dealt with, and ended up in bed for a couple of days with a really horrible pain flare.
I'm sorry if I didn't mean to put you on the spot with that story.
It's all right. I'll be a public speaker, sure.
well, and I volunteered. Sorry.
Thanks for putting my story. HIPAA. No. So it really surprised me, and it was something that I think that we need to be aware of as we're talking about a plan for people that have these histories and the pain associated with it. In that someone putting their hands on you very well, and not saying that it was for me, but someone touching you could even be just the most simple trigger. But it wasn't that for me. What it was this particular chiropractor saw me as a peer, and so he was speaking to me as a peer and called me out on my trauma history and said, "You have a trauma history, don't you?" And it just shocked me that somebody could see behind that mask. And I wondered if everybody else could see that too. And so that was really hard and something emotionally that I had to process. And it took a couple of weeks to really get through all that. I haven't gone back to him either. So, nice guy, great chiropractor, but it wasn't effective because I wasn't ready for it. So.
And I think that what you said, like I haven't gone back to him, happens a lot. It happens a lot in rehab, for example, when somebody, you know, a physical therapist asks a patient to do something and it's painful and they don't understand the difference between pain and harm, and they say, well, the physical therapist hurt me, I don't want to go back, and then we being empathizers say, oh, well, you don't have to do that, right?
Yeah.
Well,
And you had a similar kind of
well, the
story.
other thing is that chiropractic, you know, I always thought chiropractic was just
And
whack.
I'm married to a chiropractor, so I'm not dissing chiropractic.
No, and so the thing is that I was injured. I was like rear-ended twice in 2005. It was like I had a red thing hit me, please, you know. So you know, and in 6 weeks. So I have CSS, crampy spine syndrome. So anyway, I went to my physical therapist who I trusted out at Meridian Park. She was awesome. But then and was helpful, but I wasn't getting very far. So then I actually worked with some peers. I did some fibromyalgia research, and one of my other nurse friends, peer at OHSU, said, "Oh, you got to try this. Go to this Alice Capitano, or Kim was her name at the time." And she said, and she trusted. I didn't really trust chiropractors. I thought they were quacks. I mean, you know, because there are some that do it as a business, but she was awesome. And so I went to her, and she was great, and it really helped me progress. But then I tried to go to this guy, and I probably won't say his name, but that everybody said he's so great and everything, and I went to him, and he just freaked me out. And he didn't even touch, it wasn't that he touched me bad, it was a different experience, and actually, but she's really excellent, and I got farther with that. And my point is they're not all the same. But bottom line, you know, it's like, a chiropractor is not a chiropractor, as well as a physical therapist is not a physical therapist, as well as a counselor is not a counselor.
And I would say it has less to do with the specific hands-on skills and more to do with that ability to figure out how to prioritize.
Yeah.
And when to address what.
Right. And then go to a chiropractor first wouldn't have worked, but, you know, for me, I mean, but right? Because so it is, everybody's different too, and you gotta, help people and listen to them and see where they want to go to, work partnership, you know. And also that fear piece, if they went, just because they went to a bad one or somebody that was not so good for them, I should say it wasn't a good fit for them. How about that? They're not necessarily bad, but.
Well, so that brings up a really good point, which is, you know, we've all have patients come to us and say, well, I did blah, 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 and it made me worse, right? Or I had this, my doctor was terrible and didn't understand me, and this gets back to the thing about kind of apologizing for having gotten it wrong. Well, not only did we get it wrong about opioids, we got it wrong about pain, right? And that's a really helpful thing to say is, you know, can we regroup here? You've had pain for 15 years, and we now understand pain in a really different way than we did before. It's really important for me that we understand together more about pain so we can understand together what your pain story is, so we can develop a plan of care that makes sense for you. And I think that, you know, you may know a lot of these things already, but I need to understand what you know and what is part of your experience. That's kind of the context in which we have people use the videos in the classes. So, but great comments and discussions going on. But in a moment, I want to kind of map out a care plan together, but any other thoughts that people had from the conversations before we do that? Any ideas about sensory cortical changes or imbalance of arousal?
That was kind of a complicated topic.
Okay.
To really think about.
To think about. So what's complicated about it? Let's see if we can break it down.
Well, I mean, you kind of touched on the imbalance of arousal and like that alternative therapy where you like mirror the mirror neurons.
Oh, yeah.
Is that what that's like leaning towards, or I'm not really sure?
Yes, but sensory cortical change can happen just as you slowly get back to moving. So if a physical therapist or even a nurse helps somebody begin to slowly return to activity, kind of staying down at that sore but safe zone, and starts to, so you have a patient who says, I can't do anything. I lie in bed all day long and watch television because if I get up to move, I hurt and I can't stand it, right? If they start to first understand the difference between pain and harm, and then you find a baseline of like, okay, let's see if we can start to gradually increase your activity a little bit so that we can help your system become a little more resilient. I think that's going to begin to quiet down the amount that pain is ruling your life. You'll still have discomfort, but you'll be able to do more. Does that sound good to you? Great. Then you slowly begin to coach them back just to simple things like, let's try how about just wiggling side to side? How does that feel? Can you do that? Great. Could you do that about 10 times, 5 times a day? Could you do this? Great, that's just getting your spine moving. That changes the sensory cortex.
Okay.
Yeah.
I think I was just kind of unclear, I guess, based on the education today. I wasn't super solid on the meaning of sensory cortical change, but I remember the diagram and everything. You know,
right,
like
and so
the
sensory
wording.
cortical change means that blurring and smudging of the sensory cortex. Right, yeah. And then imbalance of arousal is that biasing towards the sympathetic nervous system. So, good motivational interviewing skills start to help a person change their imbalance of arousal, at least in terms of their relationship with you, right? And then in behavioral health or in their own physiological quieting work, if they're religious and they do prayer, you know, there's things that are non-clinical as well that can help with all of these things. Music, yeah.
So when you're talking about imbalance of arousal, are we talking about what we were going over with PTSD and the squishy?
Same thing. That was the same thing.
Yeah.
Yep. So so things that would help Lainey, let's just write them down here. Just like treatment interventions or things she could do on her own. Let's just shout them out and I'll write them down.
Guided relaxation.
Relaxation?
Yeah.
Okay. Guided relaxation. Okay, like that she would download.
Yeah, she could do that.
Talk therapy.
Talk therapy. Would you be my scribe, honey?
Yeah.
Talk therapy. Okay. And in specific, cognitive behavioral therapy and acceptance commitment therapy are considered the most effective ways to approach chronic pain.
And for the PTSD diagnosis, EMDR would be sort of the gold
Okay.
standard.
Yeah. Warm water exercise, who said that? Yeah, great. Warm water exercise because it's easier for a person to be in the pool. They're able to feel more relaxed when they do it. She would want to start out very gradually because you can really overdo it. But people, when they're in that gravity eliminated environment, can do things that much more comfortably that they can't do on land. So that's a great one.
I think her dog is really important to her, and something she can do with her dog, because that's safe. So,
Something she can do with her dog. Excellent. So what did that bring in? Let's talk about what that does. What does that do for Lainey?
Helps her regulate her depression.
Regulates her depression.
It's safety.
She feels safe.
And it focuses on her strength, something she feels like confident with.
Right. She feels confident in taking care of the dog, and it's a motivator because the dog needs to walk, and she feels safe walking with the dog. And that's awesome. So exercise or activity with Lainey. Maybe you even going to the park. It doesn't necessarily have to be anything that helps her. If she's been using the walker and avoiding being out, and she gets out into the world and she starts talking to people and she walks to the park, it doesn't have to be exercise. It doesn't have to be with a clinician.
How
That's
about
a good
joyful
one.
movement?
Joyful movement, like
Reframing it, well, no, just reframing
joy-
it to, from exercise, because people hate that word. You know,
Right.
there's a lot of connotations with it to joyful movement.
That's a great one. So do you ever like to just dance? And do you remember dancing in your kitchen to music?
Yeah.
Could you do that once a day? What do you think? even if it's just a little bit, yeah. What else would be a good treatment intervention for her? So we've got behavioral health, several different flavors. We've got different kinds of exercise, either clinically based or not.
Acupuncture, if she can tolerate it.
Okay, acupuncture. Can we put in pain education as a treatment intervention? Just for me?
For sure.
Um,
The first thing.
How about looking at her nutrition?
Okay.
I know we didn't really
Nutrition,
talk
we
about that,
didn't,
but
yes.
nutrition and sleep are huge.
Nutrition and sleep are huge, right. And sleep, I think these other things that are being brought up would help her sleep, right? So relaxation and exercise and talk therapy would all help her with her sleep, but nutrition, not so much. Good point.
Well, nutrition actually could help her with her sleep, because if people eat, dependent on how they eat, that does make a difference.
Or when they eat.
Well,
Yeah.
but it's also like, definitely if people eat cleaner diets, they do sleep better. I mean,
Right.
and as well as the exercise, or the joyful movement would also will help with the sleep.
And I think it's important, the pain education piece circled really to highlight that that should be the very first piece. Because I'm just thinking, not only in my clinical experience, but my best friend struggles with persistent pain. And I'm just thinking of all the different doctors she's been to, and pain education is just not, it has not been highlighted.
And so nothing else really makes sense,
And so nothing
right?
makes
I
sense,
want you
yeah.
to, I do some relaxation work.
Why?
What?
Yeah.
Go away.
Yeah.
Right, and that's
Yeah.
a place where you can get the peer coordination to help you tease out what will be the best plan
Yeah.
for the person, with the person.
So great segue. Let's talk now, and there's more we could add to this. We can put chiropractic on here. Let's prioritize now. She's in the room with you. Where do you want to start with her?
The burning thing is the PTSD. I mean, the trauma piece, right? Well, it's education, but the trauma, because you won't get very far, if you don't deal with the trauma first.
I would tend to agree with that. So, to your point, pain education is fundamental, and with her, because she has a trauma history, she's got some catastrophizing, too much of it is going to overwhelm her. So just enough, like we now understand that pain is actually a result of a lot of different things. And it sounds like you have a couple of things going on in your spine, but I think there's probably a lot of other things going on that we haven't been able to help you with as much yet. And I think if we do, that you're going to start to feel a lot better. So I'd love to help you get a little bit more information about how pain works, but I wonder first if we could try a little bit, we just try something, and you could just do a relaxation session with her for 5 minutes and just ask her how she felt afterwards. Sometimes is a really helpful way to get across a message, because when people experience it, they feel different, right? And that gets a lot further sometimes than the talking part does. And then so the pain education maybe would be a little bit more meted out with her. Yeah.
So let's talk about the trauma
Yeah.
piece just for a second, because I think sometimes when we think about trauma therapy, people are like, oh, let's dive in. Like, we're just going to start talking about the trauma and that's going to make it better. And I want to, if it's okay, just highlight what you said, which was that this chiropractor just like called it out. And so we really want to make sure that we don't call out or demand people start talking about trauma if we're not going to have the skills and the ability to sort of wrap that up nicely. So the way I talk about it with my patients is like, hey, let's not open that wound up today because we don't necessarily have the place to close it up. So unless you feel like you have the tools to close it up, don't open that wound up too much. And I think this is where it gets to appropriate referrals to trauma therapists. And then trauma therapy, that doesn't even start like quickly where you just like open it up and you start talking about the trauma. The first thing in trauma therapy is usually learning grounding and self-soothing skills. And so then that's gonna move into these other places where potentially these other things are gonna get woven in. So I think sometimes we talk about trauma therapy and there's just this assumption that like you just start talking about it and everything will be okay, and people will actually flood when you do that. And so to open that up too quickly or too fast can actually be detrimental to the rest of these pieces.
I think acknowledging that there's trauma though, which there we always say.
Yep.
And you're right, and getting
Yep.
them to the right place.
Like,
Yep.
I'm thinking back to the video on Lainey, and I'm wondering if maybe a logical conversation might go something like, you know, you've had pain for a long time. It sounds like it's really been ruling your life in a lot of ways. And I'm looking at your story, and it looks like there's several things that I think might be helpful for you that we haven't actually gotten a chance to do with you yet. I'd love to talk about that, but I also want to make sure that you have all the help you can get to generally help calm your system down. Do you find that everything that you're going through is pretty distressing? But does that, you know, like run that? And then I might even bring up to her, I noticed that you like to pet your dog. Does that make you feel better? I'd like to ask you if you'd be interested in talking with somebody who can help you with some other things that can give you that kind of calming work. Like that, to me, is a just like you had honed in on, is kind of a segue. Yeah, you had a comment.
Just the whole concept of a warm handoff to behavioral health and bringing them personally into the conversation, maybe not having them begin that relationship with that, but just kind of sharing that resource so that they know that it's there, and that when they're more ready, when, you know, Lainey is stable on her, you know, her depression meds and any other kind of medication regime that you medical personnel have kind of helped her with, and then moving towards that, building that relationship more intently. I know Lydia and I have carried a number of clients that I've not started doing PTSD work with, but kind of helped contain, and Lydia and I have been talking back and forth about that or those clients for a while before I start doing the heavy duty work of PTSD. So building those skills and all that type of stuff.
So I'm interested, say we want to have her get back into some exercise, and maybe we also want to have her do rehab. Thoughts about when you might get to this point, when you might focus on that, given what we just talked about.
After pain education.
Okay.
When she feels ready. I mean, asking her that question, do you feel comfortable going to a swimming pool and changing the locker room? Do you feel comfortable putting on a swimsuit and getting in the water?
So when she feels comfortable.
Yeah.
Yeah.
After you've really assessed for addiction, and substance use disorders here plays a huge role as well. It's kind of like been the elephant in the room, and that's a real pitfall in a very motivational interviewing way. If that's still untreated floating out there, then that's going to make everything you're doing here much more difficult.
And, exactly, yes. And I think what happens, this is what's been happening in my world. The physician says, I can't give you opiates anymore. I'm sending you to pain education, and then you're going to a physical therapist. Delaney, right? And she's chemically dependent with the trauma history. If you can, you know, and so actually I think another important question here is, because she's unsafe, she's on benzos and opioids, that's a safety issue. So let's put that over here and talk about that in just a second in terms of when you do what. But once these things have been put into place, though, I would say getting her moving is super important, because sensory cortical changes only happen when you start to move that part of the body again. And that's a part that has gotten left out of all of this, is just getting the person to start to get back to healthy movement, joyful movement, things that they were afraid to do but that are not going to harm them. We can't leave it out, and it can get tabled because it's so overwhelming. So just maybe kind of making your list, like it might go something like 1 and 1, you know, like these would maybe go together. 2, maybe this goes with talk therapy, and then 3, and then maybe you do manual therapy after. You know, when I coach people on who want to do manual therapy as physical therapists, like when you do what, to me, when central sensitization is running the show, you got to address that first. Otherwise, you're going to continue to get bombarded by that being the driver. Back up, if chemical dependency is underlying all of this, then you send somebody to a physical therapist and their lives are in chaos, right? And that's really the reality that this world is living in. So given her safety concerns, I'm going to ask you to address this. Given her safety concerns, how would you prioritize her plan of care?
So are you speaking from a medical perspective? Her safety concerns, like if I was the primary care provider?
If you were the person who was setting up her plan of care, yeah.
So, I mean, I think a couple things can happen simultaneously. And we actually, Rachel and I, as we made that first video, we made the second video in which she gets a referral to EMDR as we begin tapering off the benzodiazepines. That's the initial safety issue, right, is to get the benzodiazepines off there, and we don't want to do too much at once. So we get the benzodiazepines off of there, and then the trauma therapy is not really addressing trauma at this point. It's just building emotion regulation skills. And all of these things are so intertwined. Do you guys know about the concept of hypercataphia? It is the idea that we have an increased, it's kind of like heightened pain sensitivity post-opiates, except it's about emotional pain. And so people need even more emotional regulation skills in the context before we start decreasing their opiates, if we have the ability to do that in the context of thinking about safety. So if we can do that, we want to start building those skills before we pull the opiates away and before we pull the benzodiazepines away.
Yeah, great point. That timing is really critical, I think.
Yeah, absolutely. And I think if it's okay with you, Nora, we just have a couple minutes left, and so I'd love to just switch it around for questions now. I feel like we did a pretty good job of like fleshing out some of the things we would do with Lainey. So yeah.
One thing I was just going to say, it seems like within this it would be very important to explore her social world, because if she's running around with people that are also dealing with chemical dependency, that could be her whole world, and to find out what kind of support.
Yeah. So I guess I want to back up on the chemical dependency thing, because I think she probably does have a substance use disorder, but did we get any information today that told us that she had a substance use disorder? She has a history at the methadone maintenance clinic, so that's certainly a red flag. Outside of that,
And she was tapered down. We don't know why she was tapered off of the methadone. It might have been because she was on benzos and they kicked her off the program.
I guess I just want to highlight that although I think Lainey does, and in fact the patient that she's built on does have substance use disorders, is that we can't assume that people that come to us on chronic opiates and benzodiazepines have substance use disorders. Lots of folks are following the guidelines of their providers, right? Again, we created this mess. Well, it's true, and yet other than the methadone maintenance program, we didn't see any evidence. There was nothing in there that was diagnostic around substance use disorder today that we saw for Lainey. So we have to be careful about that.
I think there's also things that need to be defined as dependency and addiction.
Mhm.
They're two different things, but it helps when you say dependence for them, that their body is dependent, so that it's not, well, you were weaker and you just became addicted to this.
Yeah, I mean, that's the great thing. Thank you for highlighting that, because that's the great thing about the DSM-5, right, is that tissue dependence really has been sort of removed from the realm of substance use disorders. Lots of our folks are tissue dependent. Lainey is certainly tissue dependent. That does not mean she's struggling with a substance use disorder. Two different things. It's the behaviors related to the substance that define a substance use disorder, not withdrawal.
I'm coming from a care coordinator position, and our clinic is an opioid-free clinic. So we have patients coming in that have been on opioids. They're now being told that, yes, we'll help you taper off. And then there's having them sign contracts, and they're sending them to me. And usually they're halfway out the door. They've heard that they're not getting opioids anymore, and they're panic-stricken. How do I, as a care coordinator, help those patients in that moment? Because the providers almost have turned them off a little bit, and now they're just panic-stricken, like they've lost their cell phone and they can't find it. And they're panic-stricken that their opioids are gone. So how can I best facilitate those conversations and make them feel safe and want them to continue on? And that's where I'm at, is trying to figure out where to start.
That is a really hard place for you to be in. You carry such a heavy burden on a daily basis. And I think for me, I'll have to sort of mull that over a little bit about what that conversation would look like for you. And then just sort of reiterate that I think some of the things that we talked about here, the illicit provide illicit, might be useful for you in those conversations. Yeah, we're certainly not at the place of like, no, you know, we're not going to talk about that anymore, because you're really at a place of like validating, trying to engage them. And so I think some of those motivational interviewing skills are going to be the most useful for you.
Also, I wonder if it might be a good time to have a team conference about a lot of issues that come up, but that kind of sort of blanket approach to care and what it means.
The new formulation of, okay, we're going to have these patients with these pain contracts, they're going to sign them, and then we're going to send them to you. So as, you know, us as care coordinators saying, how can we best help these patients when we've just
Right,
really
so,
scared
right,
them.
so can the providers maybe take a little bit of a different tack?
Yeah. Okay.
Yeah.
Is there a strategy within Oregon that will address our lack of mental health providers that are trained specifically in pain management? Because in my work, I find there's a great lack.
Yeah, I can speak a little bit to the state, and I can speak to what's happening at the Tri-County level. So I'm part of a group called the Tri-County Pain and Opiate Task Work Group. And it started out as the opiate work group, and then was recognized that without a different approach to pain, we wouldn't get anywhere. And so there's 8 different spokes to the wheel, and one of them is around clinician education. Well, public education, and then also clinician education, and that means all clinicians. So behavioral health, physical therapy, there's everybody. So the work, it's kind of an octopus, because there's a lot of people trying to work on this at the same time, and we're also trying to not replicate what we're doing. But one of the things that we're looking at is having a regional conference that we can bring in all the different clinical focuses to, and everybody hear the same message at the same time. So that's one of the things that's happening. There's a website that was started by Oregon Pain Guidance in Southern Oregon, and is now also been adopted by the Tri-County area, and that's connected to the Billboard campaign you've seen called, what's the tagline? It's about opiates, it's about stopping opiates. It's not Help Portland, but you've seen it. It's like a bottle of pills. And
It's spilling over.
Hmm?
The bottle of pills spilling over.
Yeah, but there's a specific tagline. Anyway, it's connected to that. So there's a website that connects people to different resources. The Oregon State Pain Commission, which I'm on, is revising. We have a pain module, which was really antiquated. If you took it up to last year, it was pretty not that contemporary. So we have a new revision, and then what we're working on is an interactive model. The state is doing similar efforts, and we're attempting to coordinate them. There's also been summits that have happened all around the state in rural areas, mostly around opiates, not as much focus on the pain education part, some on the pain education part. So we have a long ways to go. Behavioral health is a really important piece and needs to be, I know we've been working on that just within Providence. They are well equipped to become really good at this, but they need a little bit more of the neuroscience background too. So those are some of the things I know of. There is work happening. It's a huge endeavor. You know, influencing your professional organization to take on pain education would be great. You can contact me, and I can connect the professional organization up to this multi-disciplinary education endeavor that we're doing, but it is happening.
What is that website again, the pain website, do you remember?
Oregon Pain Guidance.
You can get there through Oregon Pain Guidance, yeah.
Oregon
Pain Guidance.
Yeah, there's one, yeah.
I just couldn't remember.
And then there's a clinician side and a patient side.
It has some good videos.
Yeah.
I think everybody went through it.
And what will be coming out of the State Pain Commission is a module that's interactive and has links to it. We're working on that. So,
And so will the so OMA, like, and will nursing, when we get our license, then we'll have to take that again like the other one?
that we're hoping. that it will be required to redo it, yes, because it'll be new information.
Yeah.
But we do have to get that through the state.
Through legislation?
Yeah.
Oh, well, we can do that.
But people can do it anyway.
Well, no, right. But
Or
it'll be-
the individual organizations can choose to require it too.
Oh,
Yeah,
there you
right?
go. Yeah.
So those are the things I know of.
Yes.
Gang, I think we're about out of time. Can I just get your indulgence to give me a huge round of applause for these two fabulous?
Thank you. All right.